Good evening, Shreya sir. Good evening, Deepak sir.
Good evening. I am audible.
Yes, sir, audible. Shall we start?
Okay. Just a minute. So can we start?
Yes, sir. Okay,
So
we'll
you
start.
can present slide from your end or
So you and So, good evening, everyone. A very warm welcome to all our distinguished faculty members, respected doctors, healthcare professionals, researchers, students, industry partners, and participants joining us today. On behalf of the International Association for Integrated Oncology, IAIO, it's my pleasure to welcome you to today's virtual scientific meeting, IAIO Breast Cancer and Lung Cancer Update. Thank you all for taking the time to be with us this evening. Today's session Today's session has been thoughtfully designed to discuss the latest advances in the management of breast and lung cancer with a special focus on emerging evidence, evolving treatment strategies, and practical clinical applications. We are privileged to have renowned oncology experts who will be sharing their valuable experience and evidence-based insights throughout this program. Without further delay, let's begin today's scientific program. We now move to our first scientific lecture. It's my pleasure to invite Dr. Deepak Das, Assistant Professor, Radiation Oncologist, AIMS Hospital, Bhubaneswar, Odisha. May I request Dr. Deepak Das to kindly take over?
So, good evening, everybody. So, I will present my topic on driver negative non-small cell carcinoma, and that is the curative treatment approaches. So, can you have my slide here?
So you are share your slide, right?
Actually, that's why I have called you, like, share me the meeting ID. It is not able. I'm not able to open it in the EA.
Okay, so
Sir, you're facing issue in sharing the slide or how? Because we don't have your slides, sir. Is there any issue in sharing
No,
the
no,
slide?
I am like actually I am not able to open the Zoom because you have to just share me the link only.
Sir, on the
So,
screen you
uh,
can see share
so
button there.
it is a mobile. I am just
Oh, okay,
talking
you're talking
mobile.
from mobile. Okay,
Yes.
then maybe you have to
So that's
send
why
us
I am
your
like
slides,
telling you
sir.
to share me the meeting ID
Meeting ID.
because we
Just
have.
a minute, just a minute. I will, or maybe
So
you
I
can.
got it. I got it from the sponsor, so I'm connected.
Okay, okay, okay.
दीपक सर आप मुझे अपना पीपीटी भेज सकते हैं प्लीज, तो मैं शेयर कर दूंगी।
नहीं हो गया हो गया.
हाँ
नहीं
जी।
हो गया है शुरू शुरू का, हाँ।
It is not opening actually with the meeting ID.
So then the only possibility is that you might have to send us the slides, then we can share from our end.
यस सर प्लीज।
Because सर आप फोन पे ज्वाइन किए हैं तो आई अंडरस्टैंड उसमें शेयर करना मुश्किल होगा। Deepak said any possibility. So you are sending the slides.
Sir, slides are visible.
Yes, right now visible.
Make it full screen, Shivashri. Yes.
Uh,
So good evening, everybody. So I'll talk about the current management approaches in driver negative non-small cell lung cancer. So as you know, the lung cancer is the I think one of the most like frequently diagnosed cancer and one of the cancers who have a highest I think mortality rate and a very bad prognosis, and it is the 5-year OS rate is around 28%. But with the development of the like targeted mutations and all these kind of targeted therapy, immunotherapy, the survival is gradually increasing. And mostly these lung cancer patients, they usually present in a either locally advanced or in a metastatic cases. So majority are around more than 50% of the cases are present with like metastatic disease around around 57%. So as you see, if you see the mostly the locally advanced is which is called locally advanced unresectable. These are all like more than N2B disease. These are locally advanced unresectable disease up to N2A. We can go ahead with surgery if it is like the size of the lymph node is less than 3 centimeter single station. Then you can go ahead with surgery after neoadjuvant chemo or chemo plus IO. So biomarker testing in a lung cancer is an important step to decide like further treatment decision, particularly in locally advanced or metastatic lung cancer. So we generally, like in a common setting, we generally go for like at least EGFR and ROS PD-L1, but generally it should be a multi-panel, like a multi-gene NGS. So that should include the EGFR, ALK, KRAS, ROS1, BRAF, MET exon, all these kind of things. So because I think there are these are all targetable or actionable gene mutations. So in those patients who are like driver oncogene negative, then we have to decide on the basis of what kind of therapy should be given on the basis of PDL1 testing. So if the PDL1 is more than 50%, we can
Sorry to interrupt in between, sir, but then you have to guide her to go to the next slide. Yes.
so I think I
Maybe
have
now on which
one,
slide you are,
two,
she can
three,
go to
three,
that.
four slides.
Okay.
3, 4 slides, I think.
Okay. She'll go next. Go to the next 3, 4 slides.
One next one. Next. 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 Yes. So if you see the treatment decisions, in driver mutation negative advanced non-small cell lung cancer. So if the PD-L1 score is more than 50%, so the immunotherapy as a monotherapy is the treatment of choice. And if the disease burden is high, you can go for a combination like IO plus chemo. And in like in 1 to 49%. I think if the disease burden is less, you can go ahead with IO monotherapy. But if the burden is high, you should go for IO plus chemotherapy. If the in less than 1%, it is always a combination. Next. So there are different trials regarding different kinds of immunotherapy. So I will mostly focus on choice 01, that is regarding toripalimab in driver mutation negative advanced non-small cell cancer. Next. Next. So choice one, it is a randomized double-blind placebo-controlled trial, phase 3 trial. So they have taken all these advanced non-small cell lung cancer. So they have taken both squamous and non-squamous, stage 3B4, and treatment naive patients. There is known sensitizing EGFR or ALK fusion, and mostly the good KPS patients and tumor tissue available for PD-L1 expression. So they have randomized into 2:1, like toripalimab along with chemotherapy. So pemetrexed cisplatin or carboplatin followed by maintenance pemetrexed for non-squamous cell carcinoma, nab-paclitaxel plus carboplatin for squamous cell carcinoma. In control arm, placebo plus this combination of chemotherapy. And so the toripalimab here continued up to 2 years, and here the placebo continued also to 2 years. Here the primary endpoint is PFS, and the secondary endpoint is overall survival, PFS, and overall response rate, duration of response, and safety. Next. So if you see the randomization profile, all these characteristics, particularly the age, PS, PD-L1 expression, like the site of metastasis and the prior therapy, all these characteristics are properly randomized between the two arms, and in between also the squamous and non-squamous groups as well. Next. Next, please. So if you see the the PFS rate, PFS which is the primary endpoint, the median PFS with toripalimab plus chemotherapy, it is 8.4 month, and 1 year progression-free survival rate, it is 36.7 month, compared to the placebo median PFS is 5.6 month, and 1 year PFS rate, it is 17.2%. So around 3 month median PFS benefit, and the progression-free survival rate, it is around 20%. So there is stratified hazard ratio of disease progression or death, it is 0.49. So there is 51% reduction in the risk of progression or death, and which is statistically significant. Next, please. So if you see the subgroup analysis, I think with respect to PFS, the toripalimab performs better irrespective of or even if in any of the particularly if you see the particular characteristics like age, PS, PD-L1 expression, smoking status, pathological type, in all these subgroups, it performs better. Uh, Next, please. Next. Next slide. So in final OS analysis, If you see the median OS, it is around 23.8 month compared to the placebo. It is 17 month, and the 3-year OS rate, it is 32.5% with the IO plus like toripalimab plus chemotherapy versus 18.4%, and the stratified hazard ratio, it is 0.69. So there is 31% reduction in risk of death with toripalimab and chemotherapy. And if you see next slide, if you see the subgroup analysis, I think in most of the subgroups it does well. But I think in particularly if you see the squamous cell carcinoma and a few of the like subgroups, it does not perform well if you see the OS, but if you see PFS, there is significant benefit in squamous cell carcinoma as well. Next, next, please. So the final overall survival analysis in non-squamous cell groups. So so here the 3-year OS rate is 41% versus 18.9%, and there is the stratified hazard ratio is 0.49. So there is 51% reduction in the risk of death in toripalimab plus chemotherapy arm. So definitely the in non-squamous cell carcinoma there is significant benefit. Particularly the if you see the median OS also, it is 27.8 month versus 15.9 month, and there is around 12-month improvement in median OS. And the objective response rate also, if you see the it is around 65.7% compared to 46% in chemotherapy plus placebo, and duration of response also. It is also good. It is 8.4 month in toripalimab plus chemotherapy arm versus 4.2 month with chemotherapy plus placebo. Next slide. Next slide, please. So if you come to the safety profile, and if you see the safety profile, I think there is no like significant difference in safety profile between the two groups. And the most commonly the next slide. Most commonly, if you see the like the grade 3 risk groups in toripalimab plus chemo, mostly are due to I think due to chemotherapy, anemia, leukopenia, and thrombocytopenia. The rest others, I think, very less in toripalimab plus chemotherapy. Yeah. So it is I think this slide shows about the cross trial comparison across the different IO groups. If you see the prime here choice one trial, the primary endpoint is PFS. In keynote, it is PFS and OS. And ATEJO IM power study is also PFS and OS, and Nivo EP combination plus chemotherapy, it is also OS, and Tislely, it is PFS. So if you see the non-squamous cell, particularly the non-squamous cell subgroups, so here the median PFS is almost similar in I think almost in all the subgroups. But particularly if you see the median OS, I think it is significantly better in choice one. Like it is 27.8 month versus 16 month. And in all these subgroups, it is around 20 months, 18 to 20 months. And also the objective response rate also, particularly if you see the objective response rate in toripalimab plus chemotherapy, it is 65%. I think the rest close one is Atejo IM power study. It is 65. So I think we cannot say properly, like, because the patient populations are different, and uh, like the trial settings are different. But in cross trial setting, we can infer something that toripalimab does well in particularly the non-commercial subgroups. If you see the data about the median weight and the objective response rate as well. Next. So the addition of, to conclude here, the addition of toripalimab to chemotherapy in treatment naive patients with advanced non-small cell carcinoma results in superior PFS and OS than chemotherapy alone with a manageable safety profile. And these results support the use of toripalimab with chemotherapy as a first line for patients with advanced non-commercial non-small cell carcinoma without any driver like mutations like EGFR or ALK or any other mutation, driver actionable mutations. Thank you.
Thank you, sir. Thank you for that comprehensive and insightful presentation. So we now move to our next presentation. It's my pleasure to invite Dr. Sandeep Barik, Associate Professor, Radiation Oncologist, AIMS Hospital, Bhubaneswar. Dr. Barik, the virtual podium is all yours.
Thank you. Thank you. I'll share the slides visible.
Yes, sir, visible.
So let's get started.
Yeah.
So TNBC again is an important subset of carcinoma breast. It's a very aggressive tumor, high rates of metastasis, and one of the worst prognosis among breast cancer we are dealing with. And India, why we are discussing, because breast again is one of the highest incidence of cancer in the female in India, and TNBC burden comes around 30-31%. And Globocan, even we have Indian data series who have around similar 30%. So 30% is quite a huge number we have to address. So for TNBC, we have plethora of chemotherapy, plaquenil, carbo, adriamycin, cyclophosphamide, and now for the last 4-5 years, we are in the era of immunotherapy because these diseases are bad. So there is need of additional treatment for these patients. So from 2019, when atezolizumab was approved, then pembrolizumab, the keynote 355 in 2020. Unfortunately, in 2021, FDA withdrew the atezolizumab, and now only we are they did a similar trial with atezolizumab, pembrolizumab. These two are was used, and in 2023 we have a new player on the card, emerging player maybe, and the torchlight, toripalimab. It was approved, and then we'll see what this torchlight trial is all about. So it is a randomized, double-blind, multicentric phase 3 study of toripalimab in combination with nab-paclitaxel versus placebo plus nab-paclitaxel for patients with metastatic or recurrent TNBC with or without systemic therapy. So that design is eligibility criteria is histologically confirmed TNBC, triple negative, Stage 4 is less than equals to 1 previous chemotherapy, locally advanced, not amenable to surgery, and at least one measurable region and RECIST score and who have good PF. So 2:1 randomization, toripalimab 240 milligram Q3 weekly with nab-pacli day 1, day 8, and placebo was again placebo and nab-pacli taxol day 1, day 8, Q3 weekly, and treatment was continued. Endpoint was PFS. Secondary endpoint was OS, and stratified into PDL1 expression, previously traction treatment, and current line of therapy, first line or second line. So if you see the PDL1 subgroup, less than 1 is 0. The intention to treat population is around 30%, and CPS less than 10 and more than 10. So CPS score is well balanced with the why CPS 10 and 9, because we know from the pembrolizumab that for metastatic CPS 10, more than 10 you give pembrolizumab, and less than 10 doesn't work. So primary endpoint PFS assessed by intention to treat population. We have a very good graph showing 1 year PFS and advantage in 2 year PFS. So toripalimab plus chemotherapy having a good hazard ratio and of around 0.77%. So you can see the graphs. Although you will, this is a bad subsets of disease, so anything advantage should be accepted as a whole. So if you take the primary endpoints, the median PFS was around 8.4% for the 8.4 months for the toripalimab arm, while the placebo plus chemo was only 5.6%. And of course, you have a very good 95% confidence interval. It is a significant result, and we have a hazard ratio of 0.65. Even in some radical trials also we don't fail to achieve. So that means we have a 35% reduction in risk of progression or death. Consistent PFS benefit with toripalimab. Most importantly, with CPS score 1 to 10, because more than 10 you have options of pembrolizumab, but what about those 1 to 10? So these patients also are catered through toripalimab. They have a very good option now that and an impressive PFS and hazard ratio. So toripalimab acts in both CPS, more than 1 to 10. Of course, it has to be more than 1, but more than 1 to 10 and more than 10, both are equally effective therapy with toripalimab, both works. In all lines, first line, second line, you have a good advantage using those. OS again, median 3 years OS around 33.1 months versus 23.5 months. Significant results, and hazard ratio again at 0.69, good hazard ratio. Again in PDL1 subset more than 1, they will also have a OS advantage and a significant OS advantage with hazard ratio of 0.65%, and 32.8 months versus 19.1. That's a huge gap. Meanwhile, it process around 7-8 months. You can see the graphs quite distinguishing, and say that's why you will have a PDL1 subset, any subset you will have a response. So there is a consistent OS benefit with toripalimab in both the CPS, 1 to 10 and more than 10 subgroups. Of course, you can add chemotherapy, but there is a consistent OS benefit. And what about CPS more than 10 also? You have a toripalimab advantage, and even 1 to 10 also, which is more important, you have an advantage. So both CPS, even if it is less CPS, patients need not worry now. You can access toripalimab and use it. response rate with duration of response. So overall overall objective response rate was 66% with toripalimab plus nab-paclitaxel, and placebo was 68, while the intention to treat, this is in PDL1 subgroup, while the overall again response rates are both the similar arm, but if you see the median duration of response, chemo might respond in a short while. Of course, chemo will respond, but chemo immune, they keep the response for a longer time. If you see the duration is almost double. So if you give chemo only, they will respond for few times, but again they will progress. Then again you don't have much option for TNBC now. And that is a significant 10.8 the median duration of response, and with placebo, and have a stratified 0.55 hazard ratio and a significant result. So when we are using a new drug, toripalimab, there has to be concerns about the safety profile. So let's go to the safety profile. More than 3 serious adverse effects, around 23%, but resulting in death are very less, only 2 patients. Leading to interruption of toripalimab, we have 141 patients. Any investigator determined immune-related adverse effect, that's around 144 patients, around 30-40%, and any grade 3 investors adverse effect, like immune-related adverse effect, around 15%. So major complications are the hypothyroidism, and these are for all grades. So more than 3 grades. We have the next line, but major hypothyroidism, then followed by the rashes, hyperthyroidism, liver transaminitis, pneumonitis, and some layer like hypertriglyceridemia and lipase increase. So summary, PFS, we have more than one. We have a PFS survival of 8.4 months versus 5.6 months, again showing a very impressive hazard ratio and a significant result. In even intention to treat population, we have a similar PFS, 1 year, 2 year, everywhere. There is an advantage of ESS. OS, even in CPS more than 1, if you are reaching first line, it's 32.8 months versus 19.5 months. And in all, even in 3 years also, you have a OS advantage. So it's a consistent OS advantage. So the Torchlight trial establishes toripalimab plus nab-paclitaxel as highly effective first-line strategy, delivering significant improvements in both PFS and OS across ITT population and PDL1 CPS greater than 1 subgroup. So for greater than 1 subgroup, this is the answer. If the patient can take, start with toripalimab. A 12 months improvement in median OS across all CPS more than 1. Toripalimab plus nab-paclitaxel achieved 35% reduction in risk of progression. Median PFS 8.4 months versus 5.6 months. And importantly, clinical meaningful survival gains extend to CPS 1 to 10 subgroup, addressing a critical gap where immunotherapy options have been limited. So Torchlight defines the new role of immunotherapy and of extending meaningful survival benefit and duration of responses. Thank you.
Thank you very much, Dr. Varik, for sharing your valuable insight on immunotherapy in triple-negative breast cancer. Before we begin,
We will wait for a few minutes. Dr. Jehan is joining soon.
okay, ma'am. Participants, if there are any question, please put in the chat box.
Dr. Jahan is actually with a patient. There has been some emergency. He's joining in 2-3 minutes.
Dr. Jehan is joining in 5 minutes. There has been an emergency. He is with patient. Thank you for patience, participant. We request participants to share their question in the chat box. Good evening, answer.
Yeah, hi, good evening.
So shall we start?
Yes, please, let's go ahead.
Okay. So before we begin, it's my privilege to introduce our esteemed program director, Dr. Jehan Dabar, consultant medical oncologist and hemato-oncologist at Jaslok Hospital and Research Center, Mumbai. He is widely respected for his expertise in solid tumors and hematological malignancy and has significantly contributed to advancing evidence-based oncology practice through clinical care, research, and academic initiatives. We are truly honored to have him lead today's program. May I request Dr. Jehan Dabar to deliver the introductory remarks and set the context for today's academic discussion. Over to you, sir.
So, thank you very much. And I'm truly honored to be here. And also thankful to the IAIO organization. I think they're doing wonderful work by organizing these webinars from time to time. So, today we have an update on breast oncology and breast cancer. And breast cancer, as we all know, is a ever evolving field. There's so many new things that we need to discuss in recent data from ASCO and from ISMO. There's so many new trials, so many new things that I think is very important that we, you know, get onto such platforms, and it's a learning experience for all of us. And I'm really thankful for everybody who has agreed to participate, who has agreed to give a small talk, who has agreed to be a part of the panel discussion. So I think without delaying this any further, I would like to ask Dr. Shreyas, who's a very highly respected medical oncologist. I would say I had the honor to work with him. So I think the organizers can introduce Dr. Shreyas.
Thank you very much, sir. Our next speaker is Dr. Shreyas Salke, consultant medical oncologist, Shreyas Healthcare Center, Badlapur. Dr. Shalke, kindly begin your presentation.
Hello,
So over to you, sir. Yes.
can you share my slides I shared with you?
Sure, sir.
दार राहू दे उघडं काय problem. त्या बेडवर झोपून टाकलेलं.
The slides are visible?
Yeah.
Yeah.
So I'll just give you a cue to just move the slides and
Sure, sir.
so hello, respected colleagues, all the faculty and the organizers for this kind invite. I'm going to discuss the emerging role of TDXD in early stage HER2 positive CA breast. Next slide. So TDXD has been like a major player that has come up in HER2 positive CA breast. First, its role came up in metastatic breast cancer. Then it was compared in the HER2 low setting, and now we are even exploring its role in the early stage setting. So I'm going to discuss these two trials. That is the breast Destiny Breast 5 trial, which is its role in the adjuvant setting, and Destiny Breast 11, where we are going to evaluate the role of TDXD in the neoadjuvant setting. Next slide. So, just a quick revision about TDXD. TDXD is an antibody drug conjugate with the payload as DXD, which is a topoisomerase inhibitor with a good drug antibody ratio of 8:1, a higher membrane permeability, and bystander effect also. And in the metastatic setting, it has been especially preferred because of its brain penetrating action as well. Next slide. So recently, TDXT got an approval for two indications in early stage CA breast. One was based on the Destiny Breast 11 trial, where TDXD followed by taxane, trastuzumab, and pertuzumab for neoadjuvant therapy of adult patients with HER2 positive CA breast, stage 2 or stage 3. And another indication was based on the Destiny Breast 5, where TDXD will be used in the adjuvant setting for residual breast cancer after standard of care neoadjuvant chemotherapy. Next slide. First, I'm going to discuss trastuzumab deruxtecan in residual HER2 positive early stage CA breast, which is the Destiny Breast 5 trial. Next slide. Coming to the trial design. It was a global multi-center randomized open label phase 3 study. The key eligibility criteria was residual invasive disease in the breast and or axillary lymph node after neoadjuvant chemotherapy with HER2 directed therapy. They defined the high risk as prior to neoadjuvant therapy, inoperable early stage breast cancer. I mean, you would have T4 disease, higher nodal burden N0 to N3, then T1 to T3, or you might be having higher nodal burden like N2 and N3, or operable early breast cancer with axillary node positive disease after neoadjuvant chemotherapy. Like after neoadjuvant chemo, you are having residual disease in the nodes. And the key eligibility criteria was like this. As per standard guidelines, you need to have HER2 positive cases, either by IHC 3 plus or ISH positive. So the stratification factors were extent of disease at presentation, HER2 targeted neoadjuvant, you are using a single or dual, hormone receptor status, post neoadjuvant if nodes are positive or not. So they randomized a good 1,600 patients into two arms. One was the standard of care, that is TDM1, which was like the Catherine trial like design, where you would give TDM1 for 3.6 mg per kg 3 weekly for 14 cycles. And the second was the investigational arm was TDXD. We were using 5.4 mg per kg 3 weekly for 14 cycles. So the primary endpoint was invasive disease-free survival, and key secondary endpoint was DFS. So invasive DFS and DFS, the difference was that in invasive DFS, they calculated the local regional recurrences as well. And in the DFS, they calculated any kind of disease recurrence, and other secondary endpoints are OS, disease recurrence-free interval, brain metastasis-free interval, and safety. So I'll just skip this slide. Next slide. Next slide. So analysis of the primary endpoint. So the 3-year invasive disease-free survival rate was 92.4% in the TDXD arm and 83% in the TDM1 arm, with a hazard ratio of 0.47 and a p-value of 0.001, and the upper limit of confidence interval was 0.66. So, and the 3-year DFS rate was 92% in TDXD and 83% in the TDM1. So, next slide. So, if you look at the graph at the top, between the TDXD arm, which is in blue, and the TDM1 arm, which is in gray, there is a good separation of the curve after 12 months, and the separation goes on till 36 months. And hazard ratio for invasive disease-free survival was 0.47. And in the second graph, as you can see, again, there's a good separation of curves beyond 12 months, and it goes on separating till 36 months, and distance recurrence-free survival as well. Next slide. So coming to the subgroup analysis, as you can see on this forest plot, that across all subgroups, even if patients were less than 65, more than 65, Asian, non-Asian ethnicity, HER2 status confirmed by IHC or FISH, or node positive or node negative, the kind of disease at diagnosis or later, and previous neoadjuvant chemotherapy, irrespective of the subgroup analysis, everything favored the TDXD arm. So this is not projecting really well. Next slide. Next slide. So the again revising the key efficacy endpoints that the trial met its primary endpoint was invasive disease-free survival, and key secondary endpoints like DFS, distance recurrence-free interval. Interesting endpoint in this secondary endpoint in this study was the brain metastasis-free survival. So as you know that both TDM1 and TDXD have good intracranial penetration, and fewer number of patients in the TDXD arm suffered a brain event. That was 17 in the TDXD arm and 26 in the TDM1 arm, which was 2.1% and 3.2%. However, the at 3 years, the hazard ratio for brain metastasis was 0.64, with the upper limit being 1.17, but it is not significant, but uh, it has a significant intracranial activity, interesting application in high-risk HER2 positive cases with a delta of 7.8%. Next slide. About OS, the number of events for OS analysis are not yet mature with only 2.9% events. So, however, the upper limit is again positive 1.1 with a hazard ratio of 0.61. So it's not showing a significant signal in the OS currently. Next slide. So, most common, as you know, the disease related, the drug related adverse events, most important was interstitial lung disease in the TDXD arm, And in the trastuzumab emtansine arm, it used to be thrombocytopenia, diarrhea, alopecia, nausea, vomiting, and others. Next slide. So adverse event of special concern, like ones that we have to be very watchful for, and that was ILD. Any grade of drug-related ILD occurred in 9.6% cases of TDXD arm. So that is like a significant number, like 10% of the patients suffering ILD. And however, grade 3 ILD in the TDXD arm occurred at in only 0.9%, that is 7 cases. In and LV dysfunction occurred any grade in TDXDM, it was 2.9% and 1.7% in the TDM1 arm. However, we have excellent protocols now for monitoring ILD in TDXD, and we are becoming more and more better at gauging it at an early stage. Next slide. So my key takeaways from this study is that it's a new practice-changing update and efficacious drug in the metastatic setting, which is showing activity even in early stage setting. A delta of 9 to 10% in the DFS is attractive compared to the standard of care, and it defines the high risk HER2 positive cases as well, where you would be wanting to kind of include TDXD as the adjuvant. The weaknesses of this study that I found was pertaining to Indian scenario, this drug is costly. Toxicity concerns of ILD, especially in young patients, where 10% patients suffering some kind of interstitial lung disease is a little worrisome. Again, you would be having these patients undergoing radiation if they have undergone a BCS. And with these two, radiation and TDXD, both in the lung fields, you might flare up an ILD. Then cardiotoxic neuropathy and ILD are a major comorbidity in young patients. And another weakness is that if there's a recurrence in future, then you have already extinguished almost all kind of anti-HER2 agents already. Like in the neoadjuvant setting and in the adjuvant setting, then you are kind of clueless what you might be doing once they recur after. Though you have a lot of new agents coming up. Uh, yeah. So next slide. We are done with the first trial, that is Destiny Breast 5. Now coming to the Destiny Breast 11 trial. Now this trial is having a very, very complicated design. So Destiny Breast 11 was a randomized global multi-center open label phase 3
So you are not audible? So your voice is breaking, not audible properly.
Hello, am I audible?
Yes, sir, audible.
Sorry for the, it's raining outside. Where was I? So we are studying the study design of this phase 3 RCT. So it has 3 arms. First arm was trastuzumab deruxtecan, where you are going to give 4 cycles of TDXD, 5.6 mg per kg, followed by you are going to do paclitaxel, pertuzumab, and trastuzumab. So this is one arm, which is the investigational arm, which is now the approved neoadjuvant chemotherapy regimen. The second arm was dose-dense adriamycin cyclophosphamide. That is like 4 cycles that you are going to do 2 months of therapy. After that, you are going to do again paclitaxel, trastuzumab, and pertuzumab for 4 cycles. And the third arm, which was the TDXD arm, where you're going to do straight TDXD for 3 weekly for 8 seconds. After you complete the NACT, you're going to operate the patient. And after the surgery, based on the PAT-CR achieved or not achieved, you are going to receive the standard of care. Like if you, as per like the Catherine trial, that you might receive, if there is no PAT-CR, you're going to receive 14 cycles of TDM a month. If there was a PAT-CR, you are going to receive trastuzumab, pertuzumab to continue. If you have undergone a breast conserving surgery, then you're going to get radiation to the breast cavity or nodes, whichever. If you are having a HER2 hormone receptor positive disease, you're going to get endocrine therapy, and so on and so forth. The primary endpoint in this study was pathological complete response only. And the key secondary endpoint was other endpoints were EFS, safety, pharmacokinetics, DFS, OS, etc. So majorly, all in all, they have designed this into a three-arm study to elicit the role played by each of these components into the primary endpoint, that is the PAT-CR. So as we know, with adding dual HER2 blockade like trastuzumab and pertuzumab, we achieve somewhere PAT-CR rates of high as 60%. So we wanted to see if doing this can improve the PAT-CR rates. Next slide. So this is like a more simplified version of the same trial design. So I want to tell you that they enrolled around 300 odd patients in each arm. Okay. So with early efficacy analysis and futility analysis, the TDXD monotherapy arm was closed prematurely after they enrolled 286 patients because they saw that the probability of it achieving higher PAT-CR rates than standard of care. So here in their study, they gave dose dense AC followed by paclitaxel, trastuzumab, pertuzumab as the standard of care arm or the comparator arm. So and the investigational arm was our TDXD 4 cycles and THP 4 cycles. So analysis of the primary endpoint. Next slide. If you look at the top, you are going to see the comparison of the investigational arm, that is the TDXD followed by THP, compared to our standard of care arm, that is the dose dense AC followed by taxane THP. So as you can see that our investigational arm achieved a PAT-CR rates of 67% and the standard of care arm achieved a PAT-CR rates of 56%. So there was a delta of 11.2% in the intention to treat population. Now, historically, we have seen that the hormone receptor negative HER2 breast cancer responds really beautifully to any kind of anti-HER2 NACT. So, as you can see in the between the hormone receptor positive and the hormone receptor negative arms, the hormone receptor negative arm showed a higher PAT-CR rate delta with of 16%. So, uh, PAT-CR in the investigational arm was as high as 83% compared to 67% in the dose dense AC followed by THP arm. If you look at the graphic at the bottom, it is comparing the TDXD monotherapy with the standard of care. As you can see that the with monotherapy, the in the overall intention to treat population in the arm that was closed prematurely, we saw after available.
So your voice is not audible. One second, please.
Hello.
Hello. Yes, sir. Done, sir. Perfect.
So overall, the PAT-CR improved with TDXD THP with an overall delta of 11.2%. Next slide. Next slide. So now the previous slide. Okay, so analysis of the key secondary endpoint, the only 4.5% event maturity has been achieved as of now, and the ability to comment on the there is no DFS data is not mature as of now, so it's difficult to derive any conclusions. But based on our knowledge of behavior of HER2 positive cases, that once you achieve a PAT-CR, it generally converts into a DFS benefit. So based on this primary ability to increase PAT-CR rates as high as 83%, this drug has gotten approval. Next slide. So my key takeaway is that it is incorporating ADA and ADC for a very short duration. Like you only have to do 4 doses of TDHD in the neoadjuvant setting for high risk HER2 positive cases only. Not everybody needs to be on that. So it gave a positive primary outcome of PAT-CR as high as 83%, which is a surrogate for DFS, and it's a carboplatin-free regimen. Now there's a lot of buzz going on that we have to omit carboplatin to certain extent, that there's a non-inferiority NeoCharp study. So this is something very similar. So weakness of this study is that TDHD monotherapy failed, and cost of TDHD and ILD concerns are again there. Another major thing about this study, that the comparator arm, that is the standard of care, that they assume a dose dense AC followed by THP. Uh, Most physicians prefer TCHP as their standard of care, go to non-anthra containing NACP regimen. However, I deeply searched the paper. So it was quoted at St. Gallen conference that most physicians there are using a dose dense AC followed by THP as their standard of care for HER2 positive high risk cases. So they chose that as a associate standard of care arm. But however, our clinical practice is different. So maybe in future, if they could come up with a trial where they just compare this regimen, how well it does with the standard TCHP 6 cycles arm, then it would be more easier to digest. Right now, it is not showing any DFS benefits in the given graphs, but however, from our knowledge of increased PAT-CR rates with um, HER2 positive cases, we hope that it is showing some DFS benefit once data matures. So I have not added slides about toxicity and the subgroup analysis because it was even more difficult to interpret. But ILD rates in all three arms was 4 to 5%. As you saw in the previous study, the ILD rates were as high as 10% with TDXD when you're keeping it on for 14 cycles. But here you are using a very abbreviated dose of TDXD of only 4 doses. So that's it. That's all from my end. Thank you for patient listening.
Thank you, Dr. Shalke, for an excellent presentation. Our next speaker is Dr. Razivuddin Khwaja, Consultant Medical Oncologist, HMC II Hospital, Mumbai. May I request Dr. Khwaja to kindly take over? Over to you, sir.
Dr. Aziuddin is there in the meeting. Has he joined?
Yes, sir. Raziuddin, sir. Over to you, sir.
Hello.
Yes, sir. Over to you, sir.
Yeah. Slides. Hello.
Yes, sir?
Can you put the slides?
Yeah.
Today my topic for the presentation is abstract. One is Optima trial as per abstracts. Optima trial, and another one is Serena 6. Optima trial, first we'll discuss over it about chemo de-escalation in ER positive, HER2 negative early breast cancers. And the second one is Serena 6, which is ctDNA guided early switch for ESR1 mutation. So I'm Dr. Azizin Pacha, medical oncologist at NCI Cancer Hospital, Mumbai. Next slide. This is the first result from the Optima phase 3 randomized non-inferiority trial of test-directed chemotherapy in patients with high clinical risk, ER positive, HER2 negative early breast cancer. It's a pre-planned time-driven analysis. Next. Background. You should know that tumor gene expression assays which we use like the Prosigna assays, MammaPrint, are widely used to assist chemotherapy decisions for postmenopausal early breast cancers with up to 3 involved lymph nodes. Supporting evidence for premenopausal patient is usually mixed. There is no prospective evidence for higher levels of lymph node involvement. Optima is an international randomized trial that recruits high clinical risk patients. Hypothesis of Optima was that the number of involved nodes does not affect chemotherapy responses for low test score tumors. An Optima pilot study selected 50 gene Prosigna test assay for the main trial. The risk of recurrence score more than 60 is considered high risk, even if N0. So for that patients, they have given chemotherapy. Okay, next. This is the trial design. Main eligibility criteria: women and men aged more than 40 years with excised breast cancer. There should be no neoadjuvant chemotherapy, and it should be ER positive and HER2 negative, and nodes anyway from 0 to 9 axillary nodes are were considered. Minimum T size requirement if N0 and N1 MI. So here it was a randomized study. So one arm received chemo followed by endocrine therapy, and another arm was via Prosigna. The scores more the ROR scores if more than 60 was considered high score, and patient was given chemo and then endocrine therapy. If ROR score which was less than 60, then patient was subjected to only endocrine therapy and was chemotherapy was omitted. Next slide. Statistical data. Primary outcome was invasive breast cancer-free survival as the endpoint. Then that includes local, regional, distant relapse, and the second primary breast cancer and death from any causes. This was non-inferiority hypothesis. You mind you, 3% absolute non-inferiority margin was for invasive breast cancer-free survival was considered. An 83% power at one-sided 5% significance, assuming 87.5% 5-year IBCFS in control arm for primary analysis. This was non-inferiority hypothesis, absolute 3.5% non-inferiority margin for IBCFS. Next slide. So here you can see how is the randomization done. Around 4,429 patients recruited. Control arm received 2,215 and test-directed arm received 2,214. Control arm. So in the control arm, around 2,000, eventually 2,559 patients, out of which 2,058 received chemotherapy followed by endocrine therapy. And in the test-directed arm, after the ROR scores were seen, ROR scores were accordingly around 30% patients received chemoendocrine therapy, and around 60%, that is around 1,421 were subjected to endocrine therapy. So you can see around 2/3 patients were like omitted from chemotherapy. Next slide. This was the histogram showing equal distribution of ROR scores. In the control arm and the test directed arm, as you can see. Next slide. So patient and tumor characteristics, it was a well distributed study, but only thing is you can see more of 1 to 3 lymph nodes. 74% of the patients were only having 1 to 3 nodes. 18% to 19% of 4 to 9 lymph nodes were there, and so the more of lower and intermediate risk kind of patients of early breast cancers were there. Next. Events in the population. Any invasive cancer event were around 7.2% control arm, test rated arm 7.8%. Breast cancer recurrence on 5.7% in control arm, test also 5.9%. So there was not much significant difference. Also in the death, which was 3.5% in the control arm and 3.8% in the test directed arm. Invasive breast cancer free survival events were almost similar in both arms, control as well as test directed arm. Next. This year you can see the graph. There is almost not much of difference. Only 1.5% observed 5-year difference in invasive breast cancer free survival. Just 1.5%, but there was a hazard of 1.03. So not much significant. However, favoring mild, slightly favoring towards chemotherapy, but not significant enough. For both complete per population patient as well as RR scores of less than 60. It was the similar results were seen. Next slide. Distant recurrence free interval. Here also you see just 0.8% observed 5-year difference, slightly favoring chemotherapy, and 1% observed 5-year difference, slightly favoring chemotherapy, but hazard ratio, as you can see, 1.04 and 1.17 in complete population as well as ROR population, which is less than we have a score of less than 60. Next slide. Subgroup analysis, you can see on the intended chemotherapy, you can see anthracycline with taxanes, and the control arm was slightly better than the test-directed arm, which was can be endocrine therapy or chemotherapy followed by endocrine therapy, but not hazard ratios 1.12, not significant. Next slide. In the menopausal, premenopausal, and postmenopausal, here the low ROR score population. Here you can see 1.3% observed 5-year difference, just favoring chemotherapy, and in postmenopause also 1.3% observed 5-year difference, just favoring chemotherapy, but still hazard ratios are 1.14 and 1.04. Next slide. This is for the graph for nodal status. Here also the similar hazards were seen, 1.11 and 1.19% for 1 to 3 nodes or 4 to 9 nodes involved. So it's not much difference. Next slide. IBCFS versus stage prognostic groups, low ROR score population. Here almost mild favoring towards the chemotherapy arm than the test directed arm, but hazard ratio 1.14, just crossing unity. So no, not significant enough. Next slide. This was the sensitivity analysis for IBCFS in intention to treat population. Control arm 91% and test directed arm 89% with adjusted hazard ratios of 1.03, and IBCFS in control arm and test directed arm has adjusted hazard ratios of 1.03, and IDFS adjusted hazard ratio of 1.06. So not significant. Next slide. So this was a time-driven analysis, and all patients had been on study for a minimum of 1 year. 63% of patients have under 5-year follow-up, and most chemotherapy effect on recurrence is seen in the first 5 years. So we don't know after 5 years. We have done the now till the analysis till 1 year. So we have to know further how the graphs goes. So they were recruited only white patient mostly were of white population. Although representative of the breast cancer population of participating countries. Well, yes. Premenopausal women aged less than 40 years were excluded in the study, so we don't know about them. And cost effectiveness analysis is still ongoing because can assist and Prosigna, the cost is an issue. Next. Conclusions. Optima has demonstrated that 50 gene Prosigna test identifies a patient group with minimal, if any, chemotherapy benefit. And at most two recurrences will be prevented for every 100 patients if we are able to do for those early breast cancers with advanced risk factors, Prosigna say. So probably only two patients we can two recurrences will be prevented for every 100 patients with that. And the 50 gene test can assist safe adjuvant chemotherapy decisions. Premenopausal women aged at least 40 years treated with ovarian function suppression and patients with 4 to 9 involved lymph nodes or stage 3A tumors. So here we can safely um, avoid chemotherapy, adjuvant chemotherapy. Optima trial was designed to reduce unnecessary chemotherapy use for people with newly diagnosed hormone-sensitive breast cancer. Optima recruited more than 4,400 patients over 9 years from 6 countries. The trial compared the number of breast cancer recurrences and death in patients treated with standard chemotherapy with those having a chemotherapy decision made using Prosigna test. Everybody received hormone therapy. Prosigna is a 50 gene test performed on cancer tissue removed at surgery. Optima showed that at most 2% of patients with low test scores tumors benefit from chemotherapy. Rest, and all of them instead gets chemotherapy side effects. So you can do a Prosigna assay and avoid chemotherapy in many of the patients. The trial included premenopausal women aged 40 or older and patients with more than 3 involved lymph nodes. Okay. Optima demonstrated that 50 gene Prosigna test identifies a group of about 2/3 of patients with ER positive, HER2 negative early breast cancer who do not have a meaningful chance of benefit from adjuvant chemotherapy. So population included women aged 40 or older and patients with up to 9 involved lymph nodes. Okay. Now coming to the next trial, this was abstract Serena 6 with camizestrant plus CDK4/6 inhibitors, which versus continued AI plus CDK4/6 inhibitors after you detect a ASR1 mutation in advanced hormone positive HER2 negative breast cancer. So patients here it was a multi-center randomized double-blinded phase 3 trial. Patients with hormone positive HER2 negative advanced breast cancers who received more than 6 months of first line aromatase inhibitors plus CDK4/6 inhibitors. It can be palbociclib, ribociclib, or abemaciclib. And then patients were randomized into whether the patient will receive camizestrant with the continued CDK4/6 plus AI aromatase inhibitors until patient is there on till the patient has progressed on or ESR1 is detected versus continued AI plus continued CDK4/6 inhibitor plus camizestrant placebo. So disease progression, death, unacceptability, toxicity, or patient withdrawal, they were the factors where patients were omitted from the study. Primary endpoint being PFS by investigator, and the secondary endpoint was secondary PFS, OS, safety. Safety is a PROs. This was the trial design. Next slide. So baseline characteristic, it was well matched, well distributed. In be the age, the race, gender. Race mostly 60% were white race because the study was mostly done in European population, and performance score was 0 to 1, and 42% had visceral metastasis. Sorry, visceral metastasis. Okay. And most of them had received palbociclib as a first line. Serena 6, you can see this graph where progression-free survival graph where there is you can see as the adjusted hazard ratio of 0.44, with a meaningful median PFS benefit of at least 7% between camizestrant plus CDK4/6 inhibitor. Once patient has received that, it has shown much more benefit than patient who's continued on AI CDK4/6 inhibitors till progression. Once you detect a after 6 months, once you detect a on ctDNA ESR mutation, you can they have started without progression. They have started camizestrant. There is significant benefit as seen in this Kaplan-Meier graph. Next. Serena 6, this is by analysis by subgroup analysis. Here you can see the patients doing very well with once patient is on the hello.
Yes, sir.
No, I was getting stuck.
Yeah, please start, sir.
So here the PFS, this was PFS by subgroup analysis. Here you can see most of the patients were age with hazard ratios of 0.51 for age less than 65 and 0.35 for a hazard ratio more than more than 65 years. So benefit is seen in both the population with the if you add a third and for similar for the Asian race and the white race. There was in the geography also you can see Asian, European, North American showing benefit if you add the if you have detected ESR1 and added the tablets and in the menopausal, perimenopausal or postmenopausal, both have shown hazard ratio benefits. So next slide. So here also you can see this is the outcome in PFS2, 12-month PFS2 outcome of camizestrant showing 85.4% PFS2 benefit than the AI plus CDK4/6 inhibitor with adjusted hazard ratio of 0.52. And medium time to deterioration is also improved in cami plus CDK4/6 inhibitor group. That is around 23 months, then 6.4 months in on the only AI plus CDK4/6 inhibitor group. The camizestrant has plus CDK4/6 inhibitor has delayed TTD, time to deterioration in pain, versus AI plus CDK4/6 inhibitor. This is significant. Next slide. So as expected, some leukopenia is was this adverse event more seen in camizestrant the CDK4/6 inhibitor than the aromatase inhibitor with CDK4/6. Next. And this is similar, the leukopenia part, which I already told. Hematological adverse events. So Serena 6 in this randomized phase 3 Serena 6 trial, switching from AI plus CDK4/6 inhibitor to camizestrant plus a CDK4/6 inhibitor upon detecting ESR1 mutation on ctDNA during the first line therapy ahead of a clinical progression. Without clinical progression, significantly improved PFS of patient with hormone receptor positive HER2 negative advanced breast cancer. PFS benefit was observed across all clinically relevant patient subgroups. Camizestrant plus CDK4/6 inhibitor also delayed time to deterioration in quality of life, that is pain, and showed trend towards improved PFS too. And camizestrant plus CDK4/6 inhibitor was well tolerated with low rate of treatment discontinuation due to adverse events. So Serena 6 is the first global registrational phase 3 study to demonstrate clinical utility of circulating tumor DNAs monitoring to detect and treat emerging resistance in breast cancer. And that these findings suggest that Seren 6 approach has the potential to become a new treatment strategy to optimize first-line patient outcomes. So here you can see the role of the new role of circulating tumor DNAs, where you see the ESR1 mutation, and without having clinical progression, take the benefit of adding camizestrant and improve PFS, PFS1 as well as PFS2, and also the time to deterioration. And this is where we are heading towards for in the in this breast cancer area. Okay.
Thank you very much, sir, for presenting the latest evidence from the landmark clinical trials. Our next scientific lecture of the evening will be delivered by Dr. E.T. Parekh, Consultant Medical Oncologist, Cancer Center, Baroda. Over to you, Dr. Parekh.
Yeah,
Yeah,
can you share the slides?
Yeah, sure, ma'am.
So, thank you, organizers, and thank you, IAIO, for this opportunity. Today, I'll be speaking about redefining the antibody drug conjugate landscape in breast cancer. And basically, the two trials that I'll be discussing are the Tropion Breast 01 and the Ascent 04. Next slide, please. So just a brief about what is ADC, and the main two um, mechanisms of action of an antibody drug conjugate are obviously the apoptosis of the cell with the certain receptor that is targeted by the antibody, and along with it, it also causes a very important effect which is known as a bystander effect, which causes the death of the surrounding cancer cells also, where the receptors may even be negative. Next. So when we talk about hormone receptor positive metastatic breast cancer, usually the first, second, and third line is usually the hormonal treatment that we go for. And at the time, if in case the patient is in visceral crisis, or when the patient becomes hormone refractory, that is where the role of antibody drug conjugates as well as chemotherapy come into role. As of now, it was basically different lines of chemotherapy that we used to offer our patient, and now with the advent of TDXD, also DXD, which I'll be discussing today, and also sacituzumab govitecan. So there are multiple roles of ADCs now in hormone receptor positive metastatic breast cancer in the future lines of treatment. Next slide. So this is also just a showcase of the entire roadmap or journey of a hormone receptor positive MBC patient. Next. So coming to the so this actually is a very it shows the plethora of options of ADCs that we have in breast cancer, in the neoadjuvant, post neoadjuvant, and then the first line, second line, and third line metastatic breast cancer cases. Next, if you see, the two trials that I'll be discussing are going to be in the metastatic breast cancer cases. The first one is Tropion Breast 01, that is DXD versus chemotherapy. Next. So basically, Dato-DXd deruxtecan is a novel TROP2 directed ADC, and it consists of a humanized anti-TROP2 IgG1 monoclonal antibody, and it is attached to a highly potent topoisomerase 1 inhibitor payload. And next slide. This shows the effect or the mechanism of action. Previous slide. This shows the mechanism of action of Dato-DXd. where it acts on the cancer cells with TROP2. But in doing so, it also, with the bystander effect, it also causes the apoptosis of cancer cells without the TROP2. Next slide. So the trial design, it is a phase 3 open label randomized global study where patients with hormone receptor positive, HER2 negative breast cancer, and by HER2 negative, they mean IHC 0, 1 plus or 2 plus, or ISH negative, FISH negative. So they had included the HER2 low and ultra low patients also, previously treated with 1 to 2 lines of chemotherapy in the metastatic setting or inoperable setting, and ECOG PS 0 or 1. Randomization was 1:1, and Dato DXD 6 milligram per kg IV day, so every 21 days was given as compared to the investigator's choice of chemotherapy, and the drugs used were eribulin, vinorelbine, capecitabine or gemcitabine. Now here there were two primary endpoints. There had a dual primary endpoint, that is the PFS and the overall survival, with the key secondary endpoints. Next slide. Demographics and the baseline characteristics were well matched, and if you see, majority of the patients had received prior CDK4/6 inhibitor, which is the norm, prior 1 to 2 lines of chemotherapy, with majority receiving one single line of chemotherapy previously. Prior taxanes and anthracycline use was also seen in majority of the population, and almost 40% of the patient had HER2 low or ultra low or FISH negative. Next. The progression-free survival, which was the primary endpoint, was, as you can see from the Kaplan-Meier curve, that it was statistically significant, with 25.5% PFS benefit as compared to 14.6% at 1 year. And the median progression-free survival was 6.9 months versus 4.9 months. And the hazard ratio was statistically significant and clinically meaningful with 0.63. Next. The progression-free survival by investigator assessment was also similar, and it was consistent. Next. Across subgroups, when you see the benefit of PFS, which was the primary endpoint, is consistent in all of the subgroups. Next. So time to first subsequent therapy post this therapy was also more. So it was prolonged with Dato DXD as compared to the standard chemotherapy if we use in the hormone receptor positive MBC, which was 8.2 months versus 5 months, and statistically significant with a hazard ratio of 0.53. Next. Important secondary endpoints, that is the overall response rate, was also significant, 36.4% ORR as compared to 22.9% with the other lines of chemotherapy. The OS data were not mature, and the OS was also not statistically significant as of now, but it is still, we'll have to wait for the final results of the OS as the study is still continuing for the next planned analysis. Next. So these show the overall survival curves, which are, as you can see, the hazard ratio is 1.01. So that is still not significant. But a few factors why this could, this could be possible was that there was post the study, there was a lot of use of ADCs in the chemotherapy group also. So if you talk about overall survival, that could have altered the OS and with still getting a PFS benefit. Next. Next. Yes, so the oral safety summary. So the rate of grade 3 or more treatment-related adverse events in the Dato DXD group was less than half of that in chemotherapy. I think the at this line of treatment, we obviously look at the performance status of the patient, the quality of life, and the performance status is most of the times compromised, but the treatment-related adverse events of grade 3 were much lesser than that of the chemotherapy arm. Next. So Dato DXD did not have any ILD, which is usually seen with other ADCs. It was surprising that it was the most common side effects that the patients had, almost 50% were nausea and stomatitis. But while neutropenia, alopecia, and anemia, leukopenia, they were all more common in the chemotherapy arm. Next. So overall, considering that Dato DXD had a good and statistically significant PFS benefit, we still await the overall survival data. Like I mentioned, that the subsequent ADC treatment might have affected the survival results. The secondary efficacy and the patient-related outcome endpoints also still continue to favor Dato DXD at this analysis, and the safety profile is also favorable. So this is an important drug to look for. We still need to wait for the overall survival data to mature. But this is, and obviously at present we still have to import this drug, so cost is a major issue. But we have to keep a watch on this drug for the future. We now move on to the next trial, which is Ascent 404 trial, and which is sort of a practice-changing trial in triple-negative breast cancer, because here they've used sacituzumab govitecan with Keytruda as the first-line therapy in PD-L1 positive metastatic TNBC. Next. So the unmet need in first line is that 50% of the patients who receive the first line treatment, many of them may or may not receive second line or further lines of treatment. And there is deterioration in the quality of life in metastatic TNBC with each line of therapy. So this is an important opportunity, especially in the PD-L1 positive disease. Next. So this was the study design, where previously untreated, so first line, locally advanced unresectable metastatic TNBC were included. Here, the main point is that PD-L1 positive CPS score of more than 10, they were included, and more than 6 months is treatment in the curative setting, and prior anti-PD-L1 use was allowed, but more than 6 months since treatment. So around 443 patients were taken, randomized 1:1, and SG plus pembrolizumab. The dose of SG 10 mg per kg IV, day 1, day 8, every 21 days, with Keytruda 200 milligram every 21 days. As compared to the chemo plus pembrolizumab arm. So an important aspect of this trial design is that they have compared head to head with chemo and Keytruda, which is the first line of the standard first line therapy for metastatic TNBC. And the chemotherapy used was either paclitaxel, nab-paclitaxel, or gemcitabine carboplatin. And the endpoints, the primary was PFS with a secondary endpoint OS. And recently they had also published the data for the quality of life and the patient-related outcomes. Next. So if you see the Kaplan-Meier curve, it is statistically significant. The curves are apart, 48% versus 33% at 1 year. And the median PFS benefit was 11.2 months versus 7.8 months. Next. So an important aspect here is that it still shows they also had a PFS2, that is a progression-free survival 2, that is post use of this treatment, post this study treatment, further treatment lines that were used, they still showed progression-free survival benefit. So the median PFS 2 not reached for SG and Pembro versus 21 months for TPC, and that is a chemotherapy plus Keytruda. And it suggests that there is some kind of benefit even persisting beyond the first disease progression. So PFS2 is an important aspect of this trial. Next. So for the subgroup analysis, most of them had most of the subgroup analysis show a trend towards SG and pembrolizumab, and with a significantly better hazard ratio. Next. Important additional efficacy points are the objective response rates, which was 60% versus 53%. Overall response rate, if you see, the complete response rates were 13% versus 8%, which is very significant in TNBC. And the partial response rates were almost more or less similar. Also, the median time to response was similar, but the median duration of response was much higher, 16.5 months versus 9.2 months in the sacituzumab govitecan arm. Next. Adverse events were there, but grade 3 or more were more or less similar in both arms. Next. So, as we know, diarrhea was significantly more in sacituzumab govitecan arm. Nausea and neutropenia. Neutropenia was almost similar in both. Fatigue and yeah, so but thrombocytopenia and neuropathy, peripheral neuropathy, LFT abnormalities were more in the chemotherapy and Keytruda arm. Next. So, concluding this trial, the recently presented data, which was for the patient-related outcomes and the quality of life, which was also maintained with SG and Keytruda. With the emotional functioning and pain also favoring this arm. So it maintained the overall quality of life, patients also reported reduced symptom burden. It improved functioning in multiple domains, and so they, with benefit of significant improvement in the PFS, and hence it supports the treatment regimen as a potential new standard of care in PD-L1 positive metastatic triple negative breast cancer. Next. So this is just a glimpse or a snapshot of all the ADCs in breast cancer and how they've evolved, and all which are used in uh, uh, breast cancer. And it's going to be a tough time for us to uh, plan our treatment options. Just a note that both these drugs still have to be imported. So for our patients, it is still a road ahead till they get launched in India. Next. So thank you for patient listening, and thank you for this opportunity. Thank you.
Thank you, ma'am. Thank you for your outstanding presentation. We now move to one of the most anticipated parts of today's program, the panel discussion. To moderate this discussion, I invite Dr. Suparna A. Rao, Consultant Medical Oncologist, PD, Hinduja Hospital and Medical Research Center, Mahima, Mumbai. Joining her, our distinguished panelist, Dr. Dr. Priyal Rahul Savalia, Consultant Medical Oncologist, Kiran Hospital, Surat. Dr. Darshit Shah, Consultant Medical and Hemato-Oncologist, Sir H.N. Reliance Hospital and Research Center, Mumbai. And Dr. Madhura Ambekar, Consultant Medical Oncologist and Hemato-Oncologist, Orja Oncology Center, Mumbai. And Dr. Anjana Sainani will not be able to attend the discussion for the last minute emergency. And Dr. Yaswant Kashyap, consultant medical oncologist, he also not joining because of network issue. So we are truly honored to have such an accomplished panel of experts with us today. So over to Dr. Supanna Rao, ma'am.
Thank you so much. Thank you for giving me this opportunity. So, if nothing else, I learned so much, and I learned that I hardly had any idea about how many updates are. So, I think it'll be a good way for us to all brush up. Now, I think Dr. Priyal and Dr. Darshit also are yet to join, is what the message I got. So, I think only Dr. Madhura is on the panel right now.
Yes,
So,
ma'am.
I'm requesting if Dr. Jehan, Dr. Iti, and Dr. Shreyas also could join. I mean, we're not going to make this a viva or anything, but just to kind of get some idea about how we're using what drugs at present. Would it be possible? Jehan, is he there? Dr. Iti, Dr.
ma'am.
Shreyas?
Yes, ma'am. He's there also.
Okay, so I think you can start sharing my slides. I mean, I would like to finish on time.
Sure, ma'am.
So has anyone else joined the panel? I mean, I've not got a response from anyone. Is anyone else there? Dr. Raziuddin Khwaja, doctor, are you there?
Ma'am, we'll start. Sir will join.
All right.
I'll inform already. Yeah.
Madam, Shreyas here, I have joined, so I'll add inputs if I can.
All right. Can you start sharing the slides? Hi, Dr. Shreyas. Long time.
Yes, ma'am.
Can we start sharing the slides so we could go through this and just get an idea about how things are moving forward?
Yes, ma'am, already.
The next one. So I'm basically going to cover hormone receptor positive metastatic breast. So this just to give a case scenario. So we have the 61-year-old female who presented with a left breast lump and backache of 2-month duration. So the lump was for 6 months and she did not initially, it was not evaluated. Mammography subsequently at PET scan showed a locally advanced breast tumor along with the PET showing metastasis in the bone and in the lung. She was not in visible crisis at that point. So a breast biopsy done showed a ER which was 90%, PR 70%, and HER2 which was low. So she's basically a hormone receptor positive metastatic breast. So before I go into the management, I just like to know from whoever is available as to how many do you see who are upfront hormone receptor positive metastatic versus those who have received adjuvant and then progress?
Ma'am, lesser number of hormone positive who are presenting metastatic upfront. I feel more of patients they progress usually after hormone positive breast cancer, which was localized, treated after many years. They remain in the remission and then progress. So roughly around maybe 10-15% patient present de novo metastatic, and almost about 30 to 40% of the patient during their course of the disease progress to metastatic disease when treated earlier as a localized disease.
Dr. Shreyas, your experience? Is he here?
I'm in a procedure as witness the question.
Yes, I think there's a
Sir, your
problem.
voice is breaking.
Yeah, it's breaking. Yes.
Ma'am, I missed the question.
No, I'm just asking how many of in your practice come from upfront metastatic, breast hormone receptor positive versus those who progress from the adjuvant neoadjuvant setting.
So, ma'am, in my practice, upfront metastatic are 30%,
Okay.
and rest are like previously have some therapy and now come back.
Okay.
And majorly, ma'am, my metastatic cases are hormone positive only,
Or
like that.
no. Fine. So okay. So we initially have people treated who are then subsequently progressing. So please go ahead. So what would you like to do further for this case, Madhura and Shreyas? And if any other panelists joins, please just give us a heads up. And if Iti is also there or Dr. Aziuddin is there, Dr. Jehan. So what do you do? What do you tend to do for these patients apart from workup? Do you start treatment or can you go to the next slide? Or is there anything that you sent upfront for these patients? Any molecular testing? Madhura, Shreyas, you can unmute and speak whenever,
And
give your inputs. Yeah.
NGS not upfront, ma'am. If
Hmm.
permits, I would like to do ESR1 mutation upfront and germline
Hmm.
BRCA testing upfront.
Hmm.
Otherwise, rest I will keep for the second line.
Okay. And Shreyas?
Madam, I just go with the biopsy only, ERPR HER2 case, and that's it. And start therapy as per standard of care. Most my
Oh.
patients are non-affording, so I'll start with hormonal therapy backbone and
Mm-hmm.
palbociclib, which comes
Okay.
in PGY scheme.
All right. So what guidelines suggest is ideally to do a molecular testing at each time. So when treatment naive at progression also during each line, of course, it's not possible probably. But what probably would make sense to do for us is to do a PIK3 mutation testing, a germline BRCA testing. ESR1 mutation is a mutation which comes up on further lines of treatment. That is, for a treatment naive, it is hardly 3% or 5%. So usually it would make more sense for us to do it with a liquid biopsy ctDNA in second line and third line. The incidence goes up to 30 to 50%. So I think how I would like to take it is for patients who are upfront metastatic, like this lady, probably doing any testing is not going to change my management upfront. But if at all she was someone who had received adjuvant or neoadjuvant and progressed, say, within 2 years, that is, which was a primary or a secondary endocrine resistance, then it would make sense. So we'll see in subsequent guidelines to do a PIK3 mutation, to also sometimes do a germline BRCA testing for these patients, but ESR1 still in later lines. So just go ahead, please. So there's some data, the data is similar in Indian and Western populations. So PIK3 is more or less stable. So irrespective of which line you do it at, so you tend to do it upfront, at least for an endocrine, resistant case, hormone resistant case. The incidence around 30 to 40%. And tissue biopsies pick it up much better than liquid. You have AKT and PTEN mutations. Overall, their incidences are much lesser, but again, similar to ESR, these mutations can come up as part of endocrine resistance. So it's important for us to test this in subsequent lines also. Germline BRCA overall in a hormone receptor positive setting, this I'm talking about, is around 5 to 6%. And many of these cancers, hormone receptor positive metastatic breast cancers, can have co-mutations. So in subsequent lines, when you do, you can have PIK3 and ESR1 together, you can have PIK3 and germline BRCA together. This is apart from many other mutations which act, which could affect the responses in hormone receptor in hormone therapy. So like a TP53, GATA3, all of these cause hormone therapy resistance. And of course, other important things, ideally to send a huge panel, at least in subsequent lines, to look for tumor mutation burdens, to look for NTRK mutations, which are very, very rare. But this is how we would probably look at molecular testing. So in the upfront setting, a BRCA germline, a PIK3CA, especially if it's endocrine refractory. Like for this patient who's treatment naive so far, probably it's all right if we keep NGS testing for later. But on progression is when we tend to look for ESR1 mutations, especially because we have a target also. Please go ahead. So what are your agents of choice? So Dr. Shreyas said, so aromatase inhibitor with CDK4/6. So ideally, which would you want to choose, Shreyas? And Madhura, which would be your CDK4/6 go to B. So I think we are all going to give an AI with CDK4/6 for this patient. Madhura Shreyas.
Ma'am, preferably ribociclib. If the toxicity profile is favorable to ribociclib, that will be my first go-to drug to think for these kind of patients.
Mm-hmm. So how has your experience been with ribociclib versus palbociclib? And we tend to give generics also. I think abemaciclib, we wouldn't have, too much experience probably unless the patient has had CNS disease. It's not really a very favored drug. But how is your toxicities? What are the kind of toxicities you've seen, especially given with generic palbociclib? I think that's what Dr. Shreyas would be prescribing, I suppose.
Ma'am, ribociclib, yes, a bit more toxicity we have seen, but to manage the toxicities also is not a much a challenge of practice. But given the preferable data supporting ribociclib use in terms of OS benefit, I would like to prefer going for ribociclib.
And Shreyas, anything atypical you have seen with generics that you have given? Is he around? Okay, I think what I've seen with palbociclib is essentially I've seen some unexplained thrombocytopenias and crashing in counts within 1-2 weeks of palbociclib. So I think these days the tendency is to give original palbociclib, even though it probably just costs slightly double compared to much earlier. And of course, ribociclib would be my preferred drug also. But for somebody with cardiac comorbidities on multiple, like a polypharmacy, I think it would be slightly tricky to give ribociclib. Please go ahead. So, anything where you would prefer to just give a single agent hormonal therapy and keep CDK4/6 subsequently? I think we have the Sonia trial, which has shown. Hi, Dr. Darshit.
Hello, good evening.
Hi, good evening, Dr.
Hi, good
Darshit.
evening.
We'd like your input. So we're just going through the stage of an upfront treatment naive metastatic breast cancer, hormone receptor positive, who's HER2 low, ERPR strongly positive. So we all just discussed role of molecular testing. So anything that you have to say, do you tend to send NGS or do you specifically send PIK3 or germline BRCA upfront separately, or you tend to do an NGS for everyone upfront?
Correct. So if the patient is hormone positive progressed on first line, I would definitely like to send ESR1 and PIK3CA. If
So do you send upfront? Sorry,
not
like a
upfront,
germline BRCA
not
and
upfront,
PIK3? Uh-huh.
not upfront,
Okay.
I would not send upfront.
Okay.
Post progression on CTK4 and hormone then only I send.
Okay. All right. So any role for where you would just choose a single agent AI and keep CDK4/6 for like sequencing later with fulvestrant, say? Like we had the Sonia trial data which did show that the PFS ultimately is similar. So why push for a CDK4/6? We see many patients with just one or two bone lesions, but the tendency these days is to give a CDK4/6 and AI upfront, isn't it?
So I would like to push CDK4/6 inhibitor wherever feasible. Although Sonia trial is
Mm-hmm.
there, but the data the operator data is far more
Yes.
convincing. So if the
Yes.
patients are eligible, affordable, I would like to use it in upfront setting.
Yeah, I think that's how it is. So guidelines even these days, though this data came in 2018, and it does encourage equivalent PFS. So, but I think the tendency and even guidelines do these days suggest to give a dual combination, like a CDK4/6 with an endocrine therapy in the metastatic setting, at least in the first line, because I think the PFS also invariably is doubled compared to the single agent endocrine therapy agent. Please go ahead. So, what if this patient had recurred within a year of AI completion? That means she's like a secondary endocrine resistant. Or in this, these days now we tend to give CDK4/6 also in the adjuvant setting. So, where do you tend to rechallenge a CDK4/6, or what would you do if at all this patient was a secondary endocrine resistant patient, like in this case, like a change in scenario? Anything different?
So if the
Dr.
progress,
Madhu?
yeah, if the patient has progressed after 1 year of
Mm-hmm.
on adjuvant therapy after 1 year only, if the patient has progressed, definitely we will be changing both CDK4/6 inhibitors also, and maybe we may change an entirely different line. If the
So
patient
would
has
you do
come,
a consider an NGS at that point then?
I would consider, yes, I would consider.
That's what we tend to do. And when would you rechallenge a CDK4/6? Now we tend to give 2 years of abemaciclib or 3 years of ribociclib. Say it was
So if
given
the
in the
patient has,
adjuvant setting.
yeah, if the patient has progressed less than 1 year, I'd not be very, very keen to re-challenge. If the patient
Mhm.
has progressed after 1 year or maybe 2 or 3 years down the line, I would definitely use CDK4/6 inhibitor
Yeah.
again. And
Yeah.
depending on clinical and all these features, I may use a different backbone of AI or fulvestrant or anything.
Yeah, I guess that's what the tendency is, to do an AI or CDK4/6 rechallenge if the recurrence has been beyond a year. So you still consider them, kind of endocrine sensitive in that setting. But yeah, I
Correct.
guess in any setting and post adjuvant, especially if it's secondary resistance, we would tend to send an NGS then at that point. So please go ahead. Go ahead. We've discussed this already. So this is just for definition. So a primary endocrine resistance is within relapse of 2 years of adjuvant, starting adjuvant. Metastatic setting is within 6 months of the first line or a subsequent line of endocrine. Secondary resistance, if it's between that 2 years to 1 year post completing adjuvant endocrine therapy. And for metastatic settings, it's more than 6 months after initiating a single line of endocrine. So I think endocrine sensitive is anyone who's essentially treatment live, like this patient that I presented, or those who recur more than 12 months post adjuvant hormonal. Now, why this is important for us is till recently our sequencing would be a CDK4/6 with AI or a CDK4/6 with fulvestrant, and subsequently we would just have limited options like an exemestane or everolimus. We used to do pick 3, but again, alpelisib was not something that was easily doable for most patients. I think we have struggled quite a lot with toxicities. We would end up monitoring toxicities more than, kind of wondering if it would help efficacy wise. So I think that's where we stood all this while. But these definitions are very, very important. In fact, it decides how we approach these patients when we do molecular testing and what kind of agents we would offer. So please go ahead. So I'd like to just go ahead. So I think we are all aware of resistance. So this is just to give an idea about, what we would do. So for a treatment naive or a recurrence more than 12 months, like we said, we would not probably do a NGS testing at that point or look for mutations. We tend to do an endocrine therapy with CDK4/6. But if at all the patient has a primary or secondary endocrine resistance, that is on adjuvant therapy or within 1 year of completing adjuvant therapy, if they did progress, then we would do definitely a pick 3. In fact, these guidelines have said doing an ESR and even doing ESR, anti-ESR, an ESR1 inhibitor, a SERD upfront. But most guidelines suggest to do a pick 3 if it comes mutated to, I will be talking about the Innova 120 data. But if it comes negative, then just to do fulvestrant and CDK4/6. So for visceral crisis, I think we are all aware. The tendency is to do chemotherapy, right, for most patients. Please go ahead. So this is just the Innova 120 data, which looked at. So this is specifically for patients for first line metastatic, but for those patients who progress within 12 months of adjuvant, that is either primary or secondary endocrine resistant patients, where they gave inavolisib along with palbase and fulvestrant versus palbase and fulvestrant. Please go ahead. So they found that for those patients who were pick 3 mutated, when they gave inavolisib based arm, you can see that the PFS was much, much higher. This was 17 months versus 7.3 months. And you can see even at 2 years, there's a wide difference of almost 25% in terms of PFS. But what is important for us to remember is we do pick 3 mutation testing in case of a high risk endocrine resistant setting. It's not for everyone who's treatment naive. And it's only in this particular line is where inavolisib has been studied. So that's what we need to remember. Please go ahead. So the responses also were double. The overall survival also is in fact significant. It's 34 months versus 27 months. Please go ahead. And these trials, so what we are worried about with other pick 3 inhibitors is there's a lot of hyperglycemia, there is rash, stomatitis, diarrhea. But in inavolisib, for some reason, uh, overall the grade 3 and 4 side effects are much lesser, rarely causing discontinuation. So this looks like it's a doable drug. Of course, the authors do speak about giving antihistaminics upfront to prevent skin toxicities or to rather mitigate toxicities, and also probably even consider drugs like metformin in order to control the hyperglycemia. but it seems like a very effective combination, but we should exactly know in which setting to do, and it looks like it's going to stay here. Please go ahead. So this is Serena 6 data. So this is something that is coming in. Of course, incorporation might take time because I'm sure doing ctDNA testing subsequently is not going to be simple. But giving camizestrant in place of AI or fulvestrant along with a CDK4/6 for patients who had a progressive increasing ctDNA or a positive ctDNA in the absence of obvious METs by imaging, there does seem to be a magnificent increase in the PFS. So 16 months versus 9.2 months. So you can see the 24 months, there's almost 29% alive versus 5.4% which have progressed. Sorry, not alive. Please go ahead. So just one question, are we really incorporating the right choice? Like have there been patients wherein you've tried to do endocrine therapy with CDK4/6 rather than chemotherapy? So this was essentially a trial which looked at patients with visceral mets with or without crisis, and they found that giving endocrine with ribociclib even for patients with significant visceral disease, whether symptomatic or asymptomatic or visceral mets probably it was equivalent PFS, but for those with visceral disease, even those who were symptomatic, there was a significantly better PFS. It was 24 months versus 12 months in the chemotherapy arm. Are we incorporating right choice? Darshit,
Ma'am, for one
Madhura?
patient, I have opted for this because she was not at all willing for any IV chemotherapy. So
Okay.
because I
And
was
did she
forced to do
respond?
that,
She must have responded. She must have improved at 2 weeks or 4 weeks, like you would have called her to assess, right?
yes, ma'am. Yes, at 3 weeks there was response. Within 1 week, her
Mm.
symptoms were mildly better, but at 3 weeks
Mhm.
there was a response.
Yeah. So then are we probably doing, what about Darshit?
Yes, we are using right choice study, incorporating.
So you're doing right choice. So I think it depends. Like if the patient has, I think, liver and lung disease, we would probably tend to do chemo first and then move them to endocrine once they stabilize. But for someone with significant bone disease and probably symptomatic, we would still probably be more confident giving right choice, right? So I think that's where we are at. But this is definitely important data for us to know that, especially for patients who are not looking fit enough for chemo, then I think doing target that is CDK4/6 with endocrine also would achieve a response. I think this is very similar to the lung data where we see that TKIs do probably give better responses than chemo, even if there's significant disease. So please go ahead. So this lady progresses after 2 years. What would you do at this point? Send for an NGS like we discussed we would. There's data saying there's a 60% shift in the intrinsic subtype. So it's important for us to probably do a biopsy too. Look for the ERPR, whether there's any loss, reassess HER2, especially I think now in the setting of ADCs where we are looking at HER2 0, HER2 1 plus, HER2 2 plus. I think it's very important for us now to look at the ERPR HER2 status. And what would you do, Darshit? Send both a solid liquid biopsy? Are you sending for affording patients especially, or are we still sticking to just doing specifically ESR mutations for ctDNA, especially we have done a PIK3 earlier, but ideal would be to do an NGS, isn't it?
We do NGS, not both.
Um,
I would prefer getting a solid and tissue NGS basically. And
okay.
then if it's inadequate or something is there, then we may send a liquid NGS, but preferable solid, not both.
So are you
Because in
sending a
breast
solid,
cancers,
sorry, please
in breast
continue.
we don't. I mean, we do see some mutations, but not commonly. Like specifically, we are looking for PIK3 and ESR1 and
Yes.
BRCAs. Not much is targetable. So I also don't find much importance and relevance of sending both tissue and liquid. If it was lung, then the matter would have been different.
So I think what I would do is, Madhura, what are your inputs on this?
Yes, ma'am. If possible, both. If not, then at least tissue biopsy for NGS.
I think what would be important is to do a solid biopsy to look for all these PIK3 AKT mutant
Yes.
mutations. But I think we would probably push for a ctDNA for ESR because that is
ESR1.
obviously 40% more sensitive than the solid. And I think
Hmm.
what we sometimes, of course, now we are more sensitized, but we should do germline BRCA mutation testing, at least in this line, if we have not done it
At
upfront.
this point, at
That is
least.
something that is very, very important. So I think that's what we would do. So what options do we have further? Can we please go ahead? So obviously our therapy selection would depend on both disease factors, patient-related factors. Please go ahead. So what is the clinical algorithm? Are we practicing maintain, trial, and post-monarch, like continue the CDK4/6 with change in the backbone of the endocrine or any single agent fulvestrant? Are we doing that? Darshit?
Yes. If the patient has progressed, on CDK4/6 inhibitors, and if they are received for a long period of time, I definitely change the backbone. Or if possible, maybe use a different CDK4. If ribo is there, then we can change to abima and a different, fulvestrant kind of thing. I do that.
Yeah. Okay,
So far,
Madhura,
the
anytime
single agent fulvestrant concern, ma'am, depending on the disease burden and uh, toxicity, affordability profile of the patient. If disease burden
Yeah.
is not very great, then I would also go for fulvestrant as and when
So
required.
probably we could probably, I mean, I don't know. I have not so far changed from a palbociclib to ribo based on the maintain or to abema based on post-menarche and continue fulvestrant. But I think it would make sense for us to probably at least we tend to change the endocrine backbone continuing the CDK4/6. Though the data with palbociclib is negative, but there is data for this. Please go ahead. So please go ahead. I've done this. So this is the second line options. I think for ESR1 mutations, we have elacestrant, we have imlunestrant. For PIK3, we have capivasertib, we have alpelisib based. For again AKT, P10 or PIK3, we have capivasertib based. And for germline BRCA, we have PARP inhibitors. So what is important is for us also to do a germline at that point. And if there are no mutations, I think depending upon the disease burden, we do exemestane, everolimus, or just do a maintain or post monarch. And of course, we need to see if they are still endocrine sensitive or endocrine resistance. That is, if the progression is within 6 months refractory, then again, now I think what is important for us to remember is to do a germline BRCA, give PARP inhibitors preferable over chemo. And if we have a HER2 low, do a TDXD, or for an HER2, even for a HER2 ultra low, or even do sacituzumab govitecan. I think so somewhere these are taking precedence over chemotherapy, especially in the hormone positive metastatic setting. Please go ahead. So I'll run through these slides quickly. So this is the Emerald trial again with elacestrant, which showed, please go ahead, which showed a PFS over just fulvestrant. And again, for patients who had more than 1 year of benefit on CDK4/6, there was 9-month PFS benefit with elacestrant as compared to the comparator arm. Please go ahead. So this is the EMBER-3 trial looking at imlunestrant versus with abemaciclib versus standard of care endocrine. So this was used in the first line and second line setting, and we can see with imlunestrant and abemaciclib, the PFS is much better as compared to the standard of care, and even with imlunestrant alone. Please go ahead. So this is again something that is coming into practice, but I think what is important is then to select based on toxicities. Elacestrant causes a lot of nausea, lipid changes. Imlunestrant causes a lot of GI issues, diarrhea. So giving it with abemaciclib is going to be tricky. So I think this is a combination which would probably be preferred for a younger, fitter patient. Please go ahead. So this is the Capitello trial, again looking at capivasertib for PIK3 or AKT or P10 versus standard of care therapy. So this was along with fulvestrant, and it did show a PFS doubling. This is an important trial, is I think because capivasertib overall is a well-tolerated drug, and we don't really have much like so far beyond just giving fulvestrant or everolimus exemestane. So for patients who tend to have, there's a 40-50% chance of these patients having the mutations. So capivasertib would be an important drug for us to add to fulvestrant. Please go ahead. So this is the alpelisib, solar, and BILEAF trials. We know one is in more or less CDK4/6 naive, one is in post CDK4/6. Both have shown that it does improve the PFS. But I think alpelisib, the toxicity has been a major issue for us. So the preferred drug would be capivasertib in a PIK3 mutated setting. Please go ahead. So again, toxicities to compare diarrhea, the rash, stomatitis seem comparable, but what is important is the hyperglycemia is much, much lesser with capivasertib compared to alpelisib. Please go ahead. So this is PARP. I think that is something that is important. It's been tested in, the second line or third line and beyond, but it's coming to even first line in endocrine refractory setting. It's preferred over chemotherapy. we have drugs that is olaparib and talazoparib, which has shown a PFS benefit. Please go ahead. So I think ADCs, where would we place ADCs? Darshit, since you're working in HN Reliance, I mean, have you used ADCs for hormone receptor positive setting in endocrine refractory patients especially? Have you preferred to use it post one line of chemotherapy, and how has your experience been? I think we have all used
Yes.
probably sacituzumab govitecan more in breast, if I may say, than trastuzumab deruxtecan.
Yes.
Am I right in saying so? Yeah. And how has your
So yes,
experience
we are
been?
using NHER2 as second line. If the
Okay.
HER2 is low or HER2 2 plus, definitely will be using it. The experience
Mm-hmm.
has been good. A few patients are doing good. Tolerance also has been fair. But I think that is the
Mm-hmm.
best second line option, NHER2. If
So
with
have
the
you had to
cost is
dose
not an issue.
reduce? Have you got ILD? How have patients tolerated?
One patient actually got ILD
Uh-huh.
and we had to stop. Other patients are doing fair.
Otherwise,
We are
nausea or
we are
cytopenias
using
has not been a major issue, is it?
not really manageable
Okay. And
types.
what about sacituzumab govitecan? I think our institute we have experience
Sacituzumab,
with sacituzumab govitecan for a couple of patients. Yeah.
correct.
Mm.
Predominant in TNBC, one patient of TNBC in the third line, we are using Sacituzumab govitecan. The data is also coming for Dato-DXd.
Yeah.
So, but I mean, we have not used it till now, but there are some ongoing trials which are currently going in second line Dato-DXd. So there are so many options down the line. So looking forward for that.
Yes. Yes. Madhura, what is your take on sacituzumab govitecan or trastuzumab deruxtecan?
With growth factors, ma'am, sacituzumab is like we have managed it very well. We give almost like 1 year or so of sacituzumab. With
Yeah.
deruxtecan, with the limited experience that we have, it was also like the ILD was not much of a challenge. Other complications related to disease were the challenges for us in at least our 2 or 3 patients.
Yeah, I think one thing is something that we can't beat in an endocrine refractory setting is if at all the patient has a studded liver or if it's extensive disease and rapidly progressive, I don't know if we get enough time for any systemic therapy to essentially act. But hopefully
Got it.
ADCs will arrest progression to some extent. But we have tried it on a couple of patients who have really progressed rapidly and it has not worked also. So I think disease biology is something that is, not controllable. Please go ahead. So this is all the trials. I think better data is for trastuzumab deruxtecan as compared to the other two agents in terms of PFS. Also, the Destiny Breast 06, if I'm right, showing an OS benefit. Breast 04 showing an OS benefit for DTXD. So, like we discussed, I think more or less ADCs we have managed. Of course, ILD is a concern with a drug like TDXD. Please go ahead. So, any sequencing of ADCs you have done by any chance, Dr. Darshit? I mean, it's not really recommended. The PFS has been limited since we are using the same, drug in the ADC, the topoisomerase 1 inhibitor. But have you used the ADCs one after the other?
Not really, ma'am.
Yeah. So I think patients progressing on ADCs, then they're probably not going to do very well subsequently also. Their PFS is going to be limited overall. Please go ahead. So chemo, I think for us, it's important. I think still I have most patients who would opt for chemo than an ADC. German and BRCA, like we said, not everyone comes positive. We tend to use it post 3 lines in endocrine and early in visceral crisis. Any drugs of preference, Darshit, Madhura?
Ma'am, Patly carbo or gem carbo will be my go-to if depending on the previous exposure.
Agreed.
Do you tend to do, if at all, say it's a limited progression post third line, are we adding capestobine to, say, endocrine therapy and kind of seeing if it helps progress? Though I've seen people try it, I've not really seen too much of a benefit, but I've seen a lot of clinicians give a combination of endocrine along with chemotherapy for these patients.
Most of
How
the
has
time, the
your
situation
experience
is
been?
that ma'am, patients are not very keen on taking any IV after being treated so heavily. So that
Yeah.
in that situation, we tend to offer, and as you truly mentioned, it does not seem to give any benefit also.
And what about you, Darshit? Hello? Is he on mute?
Madam
Let me
Shreyas here.
actually-
Am I audible?
Yeah, sure. Yes, yes.
Ma'am, there's this tablet Comcapsi,
Yeah, yeah,
cyclophosphamide with
yes.
capecitabine. I have used that. It really works.
So it really works. I've had one patient of TNBC who is on in persistent PR post 1 year of using it. I had one more patient of TNBC who did seem to, I'm not sure because 3, 4 months she progressed. So I will not say it worked in that. But I'm not positive. I'm not sure about how it would work in a hormone positive setting,
Hormone
honestly.
positive, yes. I
Yeah.
also have
So that's
similar
the thing.
So,
experience with
ma'am, there's
TNBC, ma'am, but not, I think, in hormone
Yeah.
positive.
Yes, Shreyas. Yeah.
so, ma'am. Previously, there used to be one regimen called CMF.
Yes, 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 yes.
So, if you give Comcapsi and methotrexate weekly, it
Methotrexate,
becomes CMF.
similar.
So, it is
Yeah,
like very nice
yeah.
thing to do.
Yes, but I think ultimately in a hormone positive setting, post 3 lines, the PFSs do get shortened. I don't think we get more than a 4 at best 6 months PFS with these chemo drugs. Please go ahead. So I think this is just a slide. This is one of my concluding slides showing that, we have all these available now. I think what would be important is I think molecular testing coming a big way. That's kind of going to help PFS improve. It slightly doubles. I don't know how many years it will add overall to the patient, but at least it's better. So far I think we've just had CDK4/6 AI give around 2 years benefit, and then patients very rapidly progress. Every 4, 6 months we are having to change treatment. But I think that is slightly tweaked now with availability of capivasertib, with availability of imlunestrant, elacestrant. I think that's how I'm looking at it. Please go ahead. And ADCs, I don't know, once more accessible, once patients have that kind of a, you know, probably tolerance or ability to receive these drugs also, I'm sure it would add some amount of PFS. So this is just a, one of the slides again showing this is one of the recent papers which showed how they would, sequence. So I think for an endocrine resistance, NGS is paramount. Looking for possibility of giving PARP inhibitors or ADCs over chemo would be, the way to go. For a secondary resistance, again, doing NGS testing. And in subsequent lines, we would probably offer ADCs and chemotherapy. Please go ahead. Please go ahead. Please go ahead. Okay. So just last question. Anything just my last question to everyone. Anyone has had NGS given co-mutations? I think Darshit, you have done few NGS, you have said. Have you found co-mutations? The incidence is around 8 to 10% for PIK3 and ESR and PIK3 and germline BRCA. And how have you treated them? And anyone else has anything to say? Otherwise, I'm going to conclude, I think.
Really don't have any experience and not
Yeah.
seen
So even I've really not
mutations.
so far sent NGS. I think I'm compelled now to send a lot more NGS for our hormone therapy patients. So I think what is preferred is to give a PIK3 agent, and if a germline BRCA mutated, then to give a PARP inhibitor. So please go ahead. So I think these are the new ones in pipeline. Lot of partial, complete, estrogen receptor antagonists, covalent antagonists, covalent agonists, and these things are coming, which are taking in the ubiquitin pathway to kind of help, lyse the tumor cell. So I think this is what is there. Please go ahead. So I think we are way over time. I'd like to conclude. I think we have more or less an algorithm now, and I think it's important to incorporate NGS testing and figure out where we could give targets and ADCs now in the hormone positive setting. Thank you to my panelists. Anybody would like to
Thank
say
you, ma'am.
anything?
Lots of learning.
Yes, lots of learning. Thank you, Shreyas, for being a sport and adding to the panel. Darshit,
No,
thank
ma'am.
you.
Nice to see you.
Good to see you virtually at
Nice
least.
to
You had to
see you,
come.
Shreyas.
Chalo, chalo. I'm going to log off now. See you. Thank you. Thank you,
Yes, ma'am.
IAIO.
See you. Bye.
Thank you.
Thank you, ma'am. Thank you for that
Sorry, I'll
insightful
be logging off.
presentation.
Thank you so much. Thank you. Yeah.
Thank you, ma'am. As we come to the end of today's scientific program, I would like to express my sincere gratitude to our esteemed program director, distinguished faculty members and panelists, and every participant for making this academic session truly enriching. Your valuable insight and active participation have greatly contributed to the success of today's event. On behalf of the International Association for Integrated Oncology, thank you for joining us. We look forward to welcome you again at our upcoming IAIO academic programs. Have a wonderful evening. Stay safe, stay healthy, and keep advancing oncology through learning and collaboration. Thank you, everyone. Good night.